स्टार्ट करें.
Hello. Hello. आवाज आ रही है? Okay.
Yes.
Assalamu alaikum. क्या हाल है second year? This is Dr. Yasim from and today's topic is shock and blood transfusion. So let's have at it. Bismillahirrahmanirrahim. Shock and blood transfusion. All right, when you think of shock, what does your mind think of the general definition of shock, basically? Right? Generally, we would say shock is a sort of sudden, upsetting, or surprising event, or or an experience that is unpleasing, or in the past that was unpleasant, and it triggers a sort of an upsetting or surprising reaction. Hence, if we're looking at the word shock medically speaking as well, it defines an abnormality or an upset in circulation or the circulatory system that results in inadequate organ perfusion or tissue oxygenation. So both definitions are pretty much similar in their senses, but medically it's more relevant to what we are discussing today. All right, moving on. The different classifications of shock. We have obviously two broad classifications of shock. One is hemorrhagic and the other non-hemorrhagic. Hemorrhagic includes obviously a sort of bleeding out or loss of blood volume. That could also enlist one of the other further classifications of shock, which is most commonly also known as hypovolemic shock. Now, these are the other classification of shocks based on their causes. We have hypovolemic shock, cardiogenic shock, obstructive shock, distributive shock, and an endocrine shock. Okay. 5 main further classifications of shock besides hemorrhagic and non-hemorrhagic. And we're going to look at them by their causes, obviously. So if you're looking at the hypovolemic shock, we see it is due to loss of blood, could be one of the reasons due to loss of blood, hence known as a hemorrhagic shock. It could result after a extensive burn that can lead to loss of superficial epithelium, and loss of plasma can occur after that, and eventually lead also to a form of hypovolemic shock. Or we see there's loss of fluid and electrolytes that occur after, such as, for example, severe diarrhea or even diabetic ketoacidosis. What's diabetic ketoacidosis? Basically, diabetic ketoacidosis is a severe form of diabetes that usually commonly occurs as a complication of type 1 diabetes, which is also the juvenile diabetes, right? In which your immune system is the cells that produce the insulin in the pancreas, the beta cells. So in which what in diabetic ketoacidosis is basically, just summarizing real quickly over here, diabetic ketoacidosis was because of increased blood sugar levels that are remarkably increased leads to an acidic substance buildup, which is also known as ketones, and when it builds up to dangerous levels in the body can lead to ketoacidosis. All right, moving on. Moving on to the pathophysiology of hypovolemic shock, there is a compensatory responses that occur because of a hypovolemic shock, which leads to a progressive form of vasoconstriction initially, and leading up to a tachycardia and increased heart rate to trying to overcome the loss that is occurring, which further leads to increase of diastolic blood pressure and narrow pulse pressure. Narrow pulse pressure meaning there is still a continual decrease in total volume in blood. Then what happens is a compensatory vasoconstriction, which is further vasoconstriction in order to maximize the amount of blood in the body and limit blood loss or fluid loss. As a result, what happens eventually is a metabolic shift towards anaerobic or acidosis, metabolic acidosis, because not enough blood is being oxygenated. There's not enough blood to begin with in this hypovolemic shock, and an end result, there is a metabolic anaerobic or metabolic acidosis. All right, next type of shock we'll be discussing is a cardiogenic shock, and this can occur as a result of either a myocardial infarction, a cardiac valvular disease, or following after a cardiac surgery, or even myocarditis and other causes of acute cardiac failure. Uh, so these are generally all diseases or iatrogenic injuries that result in inability of the cardiac muscle to function properly, resulting in decreased cardiac output, of course. Now, in looking at the physiology of cardiogenic shock, there's certain essential things you need to know about the normal cardiac physiology, in which the cardiac output, basically the amount of blood that the heart is pumping out, is always equal to the stroke volume times that by the heart rate. Now, stroke volume depends upon the preload, the amount of blood that is pulling into the blood, the myocardial contractility, the contractions of the heart, and the afterload, the blood that is pumped out of the heart in towards the systemic circulation. And then preload, looking further, preload depends upon volume status, obviously the venous capacitance. And myocardial contractility is the pump that obviously drives the whole system, as related to the end diastolic length, the Starling's law, and afterload is the resistance to forward flow or peripheral resistance that the blood overcomes in systemic circulation as it's passing through your organs and the rest of the body. All right, in this diagram, it just illustrates the basic principles, again describing the main mode, which is the cardiac output, in which we have the formula on the top most. We see the heart rate, which is a beats per minute, times that by the stroke volume, which is the which includes the preload, the amount of blood that is pulling into the heart from the peripheries into the ventricles, right? And then you have the myocardial contractility, the heart muscle which contracts and the blood pumps out of the heart. And afterload is showing you the aorta and the systemic arteries across the body. Once the blood leaves the heart, and the arrows pointing towards the arteries, the aorta and the systemic arteries, is the peripheral resistance that the blood has to overcome in order to pass through the rest of the body after it has left your heart. And if you times the heart rate by stroke volume, we get the cardiac output, which tells us the amount of liters of blood that is being pumped per minute. Generally, what happens in cardiogenic shock is what? Either one of these is decreasing and total cardiac output is further decreased. Third type of shock that we'll be discussing is the obstructive shock. In this, there is a reduction in preload because of mechanical obstruction or the cardiac failure. So, for example, we have the first disease laid out as the cardiac tamponade, which I'm sure a lot of you already know. Cardiac tamponade is the blood that pools inside the pericardium, which is the fibrous capsule that surrounds the heart. So cardiac tamponade is basically a medical emergency, right, in which it physically limits the heart from contracting fully, hence leading to a obstruction or obstructive form of a shock. Next, we have tension pneumothorax. Again, tension pneumothorax is also sort of a medical emergency, which should be treated immediately or prevented, in which we have an immense amount of air that builds up inside your pleural cavity, which pushes your mediastinal structures to usually to one side. And what that does is it compromises your cardiopulmonary systems, hence causing again an obstructive form of a shock. The next two are embolisms, massive pulmonary embolism, or even an air embolism that can obstruct the flow of blood in the arteries, whether it's to the whether it's to your lungs via the pulmonary arteries or anywhere across your body. Okay, having a little deeper into a cardiac tamponade, we have a pic that is illustrating the technique for pericardiocentesis. And what is pericardiocentesis? It is the procedure that is done to relieve the pressure that has built up, or the blood that is built up around the heart in the pericardium, to relieve the obstructive nature of the shock. How is it done? We have a needle, right? That's obvious. It's angled at 45 degrees, right, from the horizon. Or if the patient is laid down in a supine position, meaning he's lying down on his back looking up. Uske baad, we angle the patient to 10 to 15 degrees, head side up a little bit, and then we position the needle 45 degrees from the sternum or the xiphoid process. And there are two types of the pericardiocentesis. There's either the infrasternal angle, which is shown in this picture, like to pierce the top left side of the patient towards the heart, basically, or the parasternal, shown here, was basically you point the needle again towards the top left side of the patient, but making sure that you pierce the either fifth or sixth intercostal space at the left sternal border. And in this picture, you see the angle being clearly shown, 45-degree angle. The pericardium, the fluid that is built up around the heart in this space, that is limiting the heart from to perform its full capacity. Okay, the next one that we're going to discuss is the tension pneumothorax, also another form of obstructive pattern of shock. Briefly, just looking at this chest x-ray, without looking at the texts on this side, if you could see the similarities or asymmetricism differences between the right and the left side, they're kind of obvious. And if you further dive into this, we see there's an increased black area on this side as compared to this side, right? Along with that, the most important thing is the shift of structures completely from this side onto this side. This is obviously the mediastinal structures, the heart and the trachea as well up here, and they've been drastically shifted on towards the left side, occupying a majority of the left side of the lung. The right side on an X-ray appears completely black, even though this one appears slightly black as well. But if you were looking at a normal X-ray, you would see it's slightly hazy, and you can appreciate the bronchioles and bronchi up to this extent. But however, unable to see any of the structures within the side, and a completely black lung should raise you an awareness that, or point towards attention pneumothorax. So what is happening in a pneumothorax is basically it's a one-way valve, and the air leaks from the lung or the chest and starts building up in the pleural space, which leads to the collapse of the ipsilateral lung, meaning the lung of this side, and shifts the mediastinum and the collapse of the opposite lung. So from this side, the ipsilateral lung, obviously ipsilateral meaning the side in which the disease is occurring, ipsilateral on that side, there's the collapse of the lung, right? And then on the contralateral side, there's the shift of the mediastinal structures. So it's compromising the cardiopulmonary vasculature and cardiopulmonary function. on this side. And a clinical diagnosis can also be made, right, based on respiratory distress of the patient. You'll be tachypneic, you'll be struggling to achieve each and every single breath. There will be tachycardia, there will be hypotension, tracheal deviation, trachea, which is going to be deviated to this side. Along with that, you're going to see unilateral absence of breath sounds. Okay, over here, it's important to note clinically that in cardiac tamponade, we're going to see similar signs as well. We'll see hypotension, jugular venous distension, along with muffled heart sounds. Okay, muffled heart sounds, and that is known as your Beck's triad. Beck's triad. Now that's a Beck's triad. Over here in tension pneumothorax, what we'll be seeing, if you're generally just comparing the signs, they'll be much similar to cardiac tamponade as well. There will be hypotension, jugular venous distension will also be seen, but instead of muffled heart sounds in pericardial tamponade, you will have unilateral absence of breath sounds. So unilateral absence of breath sounds will be in which lung? If looking at this X-ray, it will be in the right lung, this side. There will be unilateral absence of breath sounds when you're auscultating. There will be unilateral absence of breath sounds, but there will be hyperresonance, right? On percussion, there will be hyperresonance. Why? Because there's a air buildup inside this side. So yeah, there you have it. And the way to treat a tension pneumothorax is to basically puncture a hole in it with either a needle or insert a drain, a chest tube, in order to allow the trapped air inside to escape and relieve the pressure on the collapsed lung. Eventually, it would also lead to relief of the cardiopulmonary compromise that is occurring as well on the mediastinal shift. Okay. Moving on. The next type of shock that we'll be discussing is a distributive shock, and in which there's a basic pattern of cardiovascular responses. It describes the pattern, right? So for example, in distributive shock, there are different entities such as a septic shock, anaphylactic shock, or even a spinal cord injury, also known as a spinal shock. And in endocrine shock, it may present as a combination of hypovolemic, cardiogenic, and distributive shock. So in further examples can include hyperthyroidism, hypothyroidism, or even adrenal insufficiency. All right, over here, we have a nice table highlighting on the far left the different types of shock. You have the hypovolemic, cardiogenic, distributive, and obstructive. The four, basically distributive encompasses all the other, right? Addisonian crisis, the endocrine part, anaphylactic, and also the neurogenic shock. Starting with hypovolemic, and we have the different parameters, right, that will help us identify what type of shock it is and what happens in each type of shock. And according to that, we can tailor our treatment towards that type of shock as well. So if you're looking at hypovolemic shock, we have an intravascular volume loss, hemorrhagic, and fluid loss. As we discussed, it could be either hemorrhagic or non-hemorrhagic. In areas as well, ketoacidosis, they could inform the shock. Preload, the PCWP, pulmonary capillary wedge pressure, which is basically the approximation of the left atrial pressure, is decreased. Cardiac output is also decreased as a result. Systemic vascular resistance that is seen in the afterload is increased. All right, to increase the what happens, the SVR increases. And as a result, what's happening, perfusion is decreasing because there's an ongoing volume loss that needs to be overcome before anything else. And if that does not occur, the SVR will continue to decrease, cardiac output will decrease, and oxygen saturation will eventually decrease. And that is the cycle that it keeps happening until there's death. Treatment for that is basic, simple fluids. And depending on extent of hemorrhagic loss, obviously, along with fluids, we can also give blood. All right, moving on. The next type we have is a cardiogenic, right? It could, in signs or symptoms, we have arrhythmias, or as a result of which could be acute myocardial infarction, valve failures, cardiomyopathy, pericarditis could also be one of them, and pulmonary embolism. In this, what happens, the pulmonary capillary wedge pressure or the preload is increased, the cardiac output is still decreased, afterload is increased, but again, oxygen perfusion is decreased, right? So what we need to do is, in treatment, we need to stabilize the heart. We give inotropic agents such as dobutamine or dopamine to increase the efficiency and contractility of the heart. All right, next we have is the distributive form. Uh, in this, obviously, vasodilatory, right? It is vasodilatory, right? So there's decreased SVR, systemic vascular resistance is drastically decreased. As we see in all of the other type of shocks, we have an increased SVR, except for the distributive shock, in which there is a decreased SVR. So this is one thing that is different in distributive shock. Uh, right? Distributive, again, we have a septic shock, SIRS, TSS, anaphylaxis, neurogenic shock, drug toxins can also cause it, and an Edisonian crisis. And this, what do? We give, obviously, norepinephrine for neurogenic and septics. Epinephrine can also be given for anaphylactic. Phenylephrine for neurogenic, and then dopamine as well. Obstructive, in which, like we discussed in detail just briefly, just recently, we have the tension pneumothorax, tamponade, and pulmonary embolism, in which what we have is an increase in preload, decrease in cardiac output, increase, not so drastically, but could also be a decrease in systemic vascular resistance, but mainly slightly towards an increase, along with a decrease in oxygen saturation. All right. For this, we have to do a thoracostomy if it's tension pneumothorax, or a pericardiocentesis if a tamponade. All right, now we can further classify all of these shocks and differentiate between them once we have a rough idea of their signs and symptoms of shock. A lot of them are similar in the sense that basically they all have a hypertensive criteria, right? They're all hypertensive, blood pressure decreases. But there are certain things that stand out when you're looking at different shocks and that can help you differentiate between which and each of them. So, for example, if you're looking at an anaphylactic, which is severe allergic reaction, what happens, respiratory rate could either be increased, decreased, heart rate will increase, but there is still hypertension. So skin, what happens in the skin is what's significant here, or different. It's a flushed, swollen, itchy, pruritic type of a reaction that causes an itch, right? So that presentation on skin is what differentiates between the rest of them. Temperature is no change basically. Urine could be decreased, urticaria. So other signs and symptoms could be urticaria, right? Pruritus, decreased loss of consciousness, or bronchoconstriction can occur as well if it's a severe form. And we have a cardiogenic, right, which is a failing of the heart to pump properly. We have an increased respiratory rate, increased heart rate, but again, hypertension, and your skin is pale, cool, and clammy. All right. Temperature, there's no change. And chest discomfort is there. Okay, obviously, is related to the heart, so it's going to mimic in signs and symptoms of an MI, possibly. Syncope, right? Pulmonary edema and orthopnea is going to be there too. Hypovolemic, when there's reduced blood volume, there's increased respiratory rate, increased heart rate, again hypertension, pale, cool, clammy skin, with no change in temperature, decreased urine to anxiety, thirst, syncope, weakness, confusion, dizziness, and a weak bounding pulse, right? And obstructive form, again, pretty much similar, except extremities will be pale and cool, right? Change in temperature, obviously, hypothermia will occur, or urine, and then, but an important thing again, we have as signs and symptoms, further differentiating between which type of obstructive, again, As we discussed, JVD will be common in both, could be possible. Hypotension will be there, but a muffled heart sound will suggest a cardiac tamponade, whereas diminished breath sounds on one side of the lung will help you diagnose it as a possibility of tension pneumothorax. Neurogenic will have a severe central nervous system damage, in which there will be an increased respiratory rate. There will be heart rate will be decreased. Hypertension will occur as well. All right. So in this neurogenic, what's happening? The different thing is the heart rate's decreasing, right? And the skin, as a result of neurogenic, is warm, flushed, and dry. All right, warm, flushed, and dry. Now, if you remember, if you go back a little bit in neurogenic, the distributive type, what's different here is the SVR, right? So systemic vascular resistance, which causes vasoconstriction of the systemic arteries, is decreased. What's happening here in the skin? They're warm, flushed, and dry, right? So blood is what pulling there, right? It's not being evacuated from the systemic arteries, and that's why you have warm, flushed, dry. And other signs and symptoms, obviously, if there's spinal damage or injury, paralysis distal to injury site, and priapism. So obviously no bladder control will be there as well, loss of bladder control. Septic, obviously extreme immune system response to an infection. Respiratory rate is included, tachypnea, tachycardic, hypertension, flushed and pale and cool. Temperature will be there as well. There will be a bounding pulse and an altered loss of consciousness. All right, now we'll be looking at the initial management of hypovolemic shock. Looking at diagnosis and treatment is done simultaneously. So for most patients, treatment is instituted as if the patient has hypovolemic shock, right? So two basic principles are obviously to stop the bleeding and replace the volume. So, and initial management for any type of shock is basic that. Physical examination is obviously important as well. And then for any type of shock that's coming in, you got to know how to perform the ABCDs of trauma as well, right? For emergency purposes, you have to perform the ABCDs. In other variants and recent researchers, they've stated there's also a C before the ABCDEs, which correlates with the control of hemorrhage before the A. If you don't know what I'm talking about, basically, when we're talking about assess the ABCDs, what do we mean? We mean A for airway, B for breathing, C for circulation, D for deformities in E for the patient. And what they're stating is a C before the ABCDs, which means the control hemorrhage comes before everything else. So if you can control the hemorrhage by these two basic principles, especially the first one, stop the bleeding by either applying a tourniquet or putting pressure on the source of bleed, you can control hemorrhage and you can control the hypovolemic before the patient goes into a hypovolemic shock. Baseline recordings, obviously these are vital as well. So the vital signs, which are your heart rate, blood pressure, temperature, respiratory rate, important. Level of consciousness, how is the patient? Is he serious? Is he conscious or not? Is he knocked out? What's the urinary output of the patient? These are all important to assess the response of the therapy and initial assessment of the patient. Obviously, you have to control the hemorrhage, and along with that, IV access. Usually, IV cannula will be maintained on either side. On the right and left arm, two separate IV maintained. So in case you want to rush fluids from one side along with blood on the other, you have an adequate amount of IV access. So assess tissue perfusion as well. Okay. Now, monitoring for patients in shock. What is the minimum requirement? Right? Minimum is basically you're performing ECG, pulse oximetry, right, which is looking at the saturation of the oxygen, blood pressure, urine output, and then there are additional or more higher modalities that you can also use to further assess and monitor the patients that are in shock, which includes central venous pressure, invasive pressure methods, cardiac output, and a base deficit and serum lactate. When considering treatment of hypovolemic shock, right? So what we need to do is quite evident. that stop the hemorrhage and restore the blood loss. Replace it with as much as possible, whatever's been lost. Regardless of loss, initial treatment is always crystalloid replacement. Okay, the source of fluid, the source of fluid or blood loss must be identified, and surgical intervention is often necessary. Knowing that it will coagulate the source of bleeding. If necessary, or in most of the instances, you just go in surgically and you stop the bleeding. Now, how to estimate the amount of blood that needs to be given according to the amount that has been lost can be classified into four categories by different parameters. So, if you're looking at this table on top, we have the amount of blood that has been lost in milliliters. So, in class up to 750 ml of blood loss, what happens is the percentage wise is up to 15%. Pulse rate is less than 100. Blood pressure is normal. Pulse pressure normal or increase. Compensatory could be possible. Respiratory rate 14 to 20, right? Pretty much within normal. Urine output more than 30, pretty normal. CNS mental slightly anxious. So fluid replacement is just crystalloids on this one, class 1. 3-to-1 rule means basically per ml of blood loss, you give 3 ml of crystalloid. Class 2, we're looking at blood loss of around 750 to 1500 ml. The percentage comes out to be around 15 to 30%. Okay, the pulse rate is going to be more than 100. Uh, Blood pressure will be still normal. Pulse pressure will be decreased. Respiratory rate slightly increased now, 20 to 30. Urine output is decreasing 20 to 30. CNS from slightly anxious now, the patient has become mildly anxious, and fluid replacement is still though crystalloids. However, when we come to class 3, the blood loss has increased drastically from 1500 to 2000 ml, which is total of 30 to 40% of blood volume. The pulse rate will be increased 120. Blood pressure will be decreasing further, pulse pressure along with that. Respiratory rate will be 30 to 40. Urine output is decreased 5 to 15. Now the patient will be anxious, and along with that, obviously confused as well. The fluid replacement will start with crystalloid and blood. Class 4, which is severe blood loss, in which there is more than 2,000 blood loss, 2,000 ml of blood loss, which constitutes about a total of 40% of blood volume. Pulse rate will be more than 140. Blood pressure and pulse pressure decrease. Respiratory rate more than 35. Urine output basically unmeasurable or negligible. CNS mental status confused and lethargic. Fluid replacement will be the same as class 3, crystalloid and blood, both. So that's important to maintain a 2 IV line axis at least. Right? Uh, Different things that we can look at. Obviously, discuss whether or not, like if he's anxious, mindly status of the patient. Skin circulation that we discussed amongst the signs and symptoms of different types of shock. As cool, clammy, hot, flush. Urinary output is also a different parameter that we're looking at. For adults, the minimum requirement is 0.5 ml per kg per hour, and for children, 1 ml per kg per hour. CVP measure in complex cases, especially elderly or cardiac patients, is a important marker as well. Severe metabolic acidosis, ABGs. ABGs are arterial blood gases. Means inadequate resuscitation or ongoing losses may need operative intervention. Okay. All right. In this table, we're looking at the response to initial fluid resuscitation. Right. So vital signs, if their vital signs are estimated blood loss will be obviously estimated. Minimal, 10 to 20%. Need for more crystalloid is low. Need for blood is low. Blood preparation type and cross match. So you type and cross match. Need for operative intervention is possible. Early presence of surgeon, yes. Okay. Now, in transient response, vital signs transiently improvement, recurrence of basically decreased blood pressure and increased heart rate. The estimated blood loss will be moderate and ongoing 20 to 40%. The need for more crystallite is high. Okay. Need for blood is moderate to high as well. And blood preparation is type specific. Need for hypertension is most likely, and presence of surgeon is throughout basically all three. Yes, yes, and yes. When there's no response in initial fluid resuscitation, right, the vital signs will remain abnormal. The estimated blood loss will be severe, way more than 40%. Need for more crystallite, highly. Need for blood is immediate. Blood preparation, emergency blood release. Okay. Need for operative intervention is highly likely. So you're definitely going to go with surgical intervention and try and locate the bleeder. Okay. When we're talking about hemorrhages, certain questions always show up in tests, and you should definitely know their meaning. Basically, what is revealed and concealed hemorrhage, difference between the two. Primary, reactionary, and secondary hemorrhages, surgical and non-surgical hemorrhages. Okay. The first two is kind of obvious. This is pretty much given by the word, revealed and concealed, meaning basically revealed. Obviously, that's out there in the open. You get hurt, external sort of bleeding. You get hurt. There's a trauma. There's a cut on the skin, leg, wherever it is, and it's a sort of revealed hemorrhage. That's the external hemorrhage. Then there's obviously concealed hemorrhage, which is occurring uh, any of your tissues, muscles, cavities, peritoneum, pleural, or sort of hematoma formation. And the concealed hemorrhages can become revealed, such as in cases where there's hematemesis, right? Hematemesis, which is vomiting of blood. So it was a concealed hemorrhage that could have been happening because of a bleeding peptic ulcer that became revealed because of vomit, or an upper GI bleed somewhere around the small intestines that was bleeding constantly, an ulcer possibly, that became from concealed to revealed in the stool, which is known as melena, which is a black sort of tarry stools that occur in patients that have upper GI bleed. Tika, primary, reactionary, and secondary hemorrhages. What are they? Basically, primary occurs, as the name states itself, is pretty much given. Primary occurs immediately. So this has to do with the time length, okay, from an afflicted injury to when the bleeding is occurring. First, we discuss revealed or concealed, whether external or internal. Primary, reactionary, or secondary hemorrhage. Primary occurs immediate. You get hurt, you start bleeding right away. Primary hemorrhage. You were operating, you nick the artery, patient starts to bleed, primary hemorrhage. Within operation, usi waqt bleed hua, primary. Reactionary is what happens 24 to 48 hours, okay? After whatever trauma or surgery. So that's reactionary. When does it's most likely because of the increase or normalization of the blood pressure, usually normally after surgeries, which dislodging of the clot that was formed at the primary site of bleed or whatever it was. So that's the cause of the reactionary hemorrhage. Such as in thyroidectomy, usually after thyroidectomies, as a result of reactionary hemorrhages, it's normal for surgeons to place a drain at the site of the thyroidectomy or to deal with reactionary hemorrhages. Okay. Secondary hemorrhage is beyond obviously that time length of 48 hours and occurs secondary to the stimuli. Then you have the surgical and non-surgical. Again, it's pretty much given. Whether surgical during an operation procedure occurs because of that. Directly correlation to surgery is a surgical hemorrhage, and non-surgical because of factors other than surgery. Okay. Coming down to damage control surgery, like we stated above, over and over again, if the hemorrhage is severe and it's not being controlled, then a damage control surgery is necessary. And that should be done whether to arrest the hemorrhage, which is not being controlled, control sepsis, or protect from further injury and harm. This is more or less the last line of control that you can perform a damage control surgery. Okay, now blood replacements. What does blood replacement do exactly? It restores the oxygen carrying capacity, right? Blood should be cross-matched, which takes about 1 hour and is useful in stabilized patients. However, type-specific ABO and RH-specific blood available in 10 minutes preferred for transient responders. Okay, which was shown in this table. Basically, it's trying to describe it over here. The rapid response, right? Type and cross-match. For transient response, type specific, and no response, emergency blood release. What does that mean? Coming back to this slide, right? Stabilized patients, cross-match blood, takes 1 hour. Transient responders, type specific, ABO and RH specific, available in 10 minutes, right? Exsanguinating hemorrhage, those that are undergoing severe blood loss, right? Type specific blood is not available that readily. What you do is you give them type O blood, okay? Type O blood. For those that need it right away, you can give them type O blood. Okay, moving on. Basically, blood and blood products. What are the different types of blood products that are there? We have whole blood, right, which is blood as it is in our body, including red blood cells, plasma, along with all the clotting factors and everything. That is the whole blood. It constitutes everything within a normal blood that's inside the body, right? We see after filtration and checking for any infections and viruses, proper screening basically. Red made from whole blood, process called centrifugation, which is basically removal of the plasma from the whole blood. Then we have fresh frozen plasma, right, rich in almost all clotting factors. Then you have cryoprecipitate, which is factor 8 and fibrinogen, right? Easy way to remember cryoprecipitate. Hear the word 8 at the end. Cryoprecipitate, factor 8 and fibrinogen, all right? Fresh frozen plasma has all the clotting factors. Cryoprecipitate, factor 8. Then you have platelets, and then prothrombin complex concentrate as well. And then we have factor 2, 9, and 10, which are warfarin, autologous, which is basically what the factors that are decreased because of warfarin. Patients are given warfarin. So what's going to be warfarin, autologous blood metabolism factors 2, 9, and 10, along with proteins necessary. So management of coagulopathy, again, briefly going over this. FFPs, right? Fresh frozen plasma, which is if prothrombin time or partial thermoplasmin time is more than 1.5 times the normal. Cryoprecipitate, if fibrinogen is less than 0.8 grams per liter, and platelets, the platelet count is less than 50,000. Right? Complications of blood transfusion. Incompatibility, hemolytic transfusion reaction can occur. Febrile transfusion reactions. Allergic reaction can occur. Infection can happen. Could be hepatitis, malaria, bacterial infection, faulty storages, HIV, or air embolism, thrombophlebitis, transfusion-related acute lung injury, usually from FFPs. These were generally basic complications of the blood transfusion. We have complications from massive transfusion, which could be dilute coagulopathy, hypocalcemia, hyperkalemia, hypomagnesemia, hypothermia, and also air embolism. Uh, yeah, so there we have it. Thank you. Thank you very much.